Elaine, can you introduce yourself and tell us about what work you do for the county?
Yeah, my name's Elaine Nast. I'm a registered nurse. I'm a public health nurse. I work for the county of Santa Cruz. Started with Care Team back in, well, I was an employee back in 2014, but I was doing, 2012, but I was doing some volunteer work with them before that. I started the county in 2012 as an employee. I had been doing some volunteer work and such with them before that. But I do case management of folks with HIV, which is the mandate of the Care Team back then. And it was a hard position to get because there's never any turnover. The people who had been there for decades because they loved the work and they loved the clients. And I really got a chance to work with some of the legends of HIV care in this county before they retired.
Who are those legends?
Michaela Barkus, number one, absolutely. Founder of one of the founding nurses of Care Team and was the manager of Care Team when I came on board. And she's incredible. Like most county employees that retire, she looked 10 years younger as soon as she retired. She's living her best life up in the mountains. Robin Stone, who was the manager after her, was one of the very early nurses and was there back in the 90s. Back when Care Team was hospice work. By the time I got on board, it was getting to be more of a chronic condition. We had one pill. We had of course, the cocktails, which changed everything once we learned how to attack the HIV from 3 different places, and that would actually control it. And then once we got the 1-pill regimen, that made compliance so much better, and our clients could actually stay, rather than taking a handful of pills multiple times a day, 1 pill once a day, big game changer. So that had come out not too long before I started the work, and things were rapidly changing at that point.
Thank you. Elaine, can you talk about contemporary care for people with HIV in this county, such as populations that are more likely to experience infection?
Yeah, well, in my current role, I'm supporting folks that get their care at the county. So that is not folks with private insurance and jobs. So that's not what I see. I see people on Medicaid, Medicare. So I would say it definitely is still primarily an MSM. Transmission is definitely dominant. And MSM is men having sex with men. I would say that a good percentage of them are in the Hispanic community and the homeless community. And of course, needles are still a function of transmission, but still not nearly as much as sexual. Heterosexual sex, still a mode of transmission, still nothing like MSM sex. So that's still the core of the transmission is men having sex with men.
Why do you use the phrase men who have sex with men?
Because people don't necessarily identify as gay. There's a number of men, especially in the Hispanic community, that would never consider themselves gay. They may be married with families and kids, and they have gay sex on the down low. And so they're not going to identify as gay ever. It's about the act of having sex with a man. It's not about how you self-identify. So.
Why do you think the Hispanic or Latino population still experiences disproportionately high rates of HIV?
Some of it is, there's definite cultural things that make it harder to do outreach and education. We don't have the funding we used to have for outreach and education across the board, and that has caused an increase for sure across the board. But in the Hispanic community, you have, a high influence of the sort of Catholic cultural morals and expectations. So sex is not talked about, period, let alone anything about sexual diseases, let alone about sex with, men having sex with men. It's just harder to reach and educate in that culture for a large part. We definitely try. Most of the case managers I've worked with over the years are bilingual. was usually the only monolingual person on the staff, honestly, which was a little embarrassing. We try, but it's harder. It's just harder.
Thank you. How has public health funding changed over time with regards to HIV and AIDS?
Well, as I said, when I came on board at Care Team, things were changing so far as the treatment for the disease. You didn't have people wasting on the street corners. You didn't have people dropping dead left and right. So funding got tighter. Competition for the grants got tighter. In our case, Care Team has received Ryan White grants the whole time. We had 3 different grants that we were working under when I started. But we also took a significant piece of county funds because the county was very invested, and that was unusual. I mean, right away in the 90s, the county got in there and invested and did this care. But 2008, in the recession, things got tight and we lost a lot of headcount. That was right before I came on. I replaced somebody who was retiring, so it wasn't an additional headcount. And with the decreased headcount, we could do less and less. The county wasn't putting it, it's been putting in less and less funds. The Ryan White money got more and more competitive. Some of the expectations got higher and higher from the grants. If you're a nonprofit, you know you work under grants and you have to do all these things for this grant and all these things for that grant, and so whatever grant we were caring for a client under, everything had to be different, and it was hard. So we let go of some of those grants a couple years ago. We talked about it for a long time, but I guess it was around COVID time that stuff really happened. We let go of the waiver grant, which is sort of for the highest acuity folks, and that's now managed by the Health Project Center. We let go of the Part C grant, which was really meant to be a clinic-based grant, and we moved it down, it's still in the county, but we moved it down to clinics. It's not under public health, and that's when I moved to clinics. So whereas before I supported the whole community, and I had clients with private insurance or whatever, or public, now I just focus on folks that get their care at the center, at the clinic, which is, I don't know, it's a lot. We have about 250 maybe HIV positive clients on our rolls. So the money's dried up. The first thing to go was, of course, outreach and education, and then less for care. And it's affected what we can do for people. Whereas before, we would, we'd show up in somebody's life and we do so much. I've had people say, getting HIV saved my life. Because they were living such a marginalized life, and they, it got them to take care of themselves. They were seeing the doctor regularly. Other things were caught on time because they see a doctor regularly, whereas before they maybe never went. And just the help getting housing and all the other stuff we were doing, housing and food, and I mean, we definitely whole person care. But we had less and less resources to do that with as funding dried up. And the loss of SCAP was kind of the last nail in the coffin for that. There's very little that is HIV specific in the way of resources now. We have to, we access the same resources everybody else does for people. We try to get a Section 8 voucher, but we used to be able to get fast track to a Section 8 voucher for our people. We can't do that anymore. Things like that just went away because it's not the death sentence it was. So it's good and bad. But it's definitely harder, especially since so many of our clients that I serve are so marginalized and have so little to start with. They really need that help. And if I can keep somebody housed, I can have a chance of keeping them healthy. It's really hard to keep someone who's homeless, consistent with their meds and their appointments and their care. There are a few that are organized enough to do that, but, people, they lose their backpacks, things get stolen, then their meds are gone. And how do you replace, expensive meds a week after they picked them up? It's hard to keep some of our people happy and healthy, but it was easier when we had more of those resources.
What sort of outreach projects did your team do before you lost that funding?
So this is what I've heard because it was gone by the time I got there. But we used to take the county van. There was this big old county van that was around for a long time. It was a beater that just belonged to the health department. And we would go out, to places where the gay folks are. And a lot of times, like Buena Vista, which is the rest area is a big hookup area. And literally, I hear the stories about them being out in the bushes talking to guys while they're looking to hook up, getting testing happening. And they do mobile testing anywhere they could find the population. They'd show up at bars, they'd show up at Pride, they'd show up at anywhere the queers were. Those are the good old days.
What has been the impact of losing funding?
Well, outreach and education, definitely when I first started, they were seeing the spike of increase in transmission because we weren't doing the education we used to do. It took a couple of years for it to really start showing up, but it did. A lot of times when we have a spike locally, it's tied also with syphilis. We often get them both go up together. And so they're often co-infected, which can be challenging. Syphilis is easy enough to treat, but it has its own path within public health. So outreach and education is the big one, and then the resources. Just getting people safely housed has become. It's hard everywhere, I know. We used to have resources we don't have.
So would you say that there is a relationship between being unhoused and being able to stay healthy while?
Absolutely. Absolutely. Just taking a pill every day is hard when you're, shuffled from place to place and rousted by the cops, and you lose your possessions every time they break up a camp, and a lot of the time that involves losing your meds. Making it to appointments, when your life is that unorganized and chaotic, it can be a lot just to make it to an appointment, get your labs, do the routine stuff. If they can hold on to a phone, which some people do better than others, if they can hold on to a phone, I can often work with them and help them make appointments and, get to things. For a lot of homeless clients, we would hold their meds and give them a week at a time in a caddy, so that if they lose them, they lose a week, not a month. And HPHP still does that service for us, for folks. I work pretty closely with HPHP, with our folks too, especially for just finding them. COVID time was kind of fun, in that we had the IQV motels and all the compromised folks were in those hotels, which meant everybody with HIV I got a room for. I had everybody inside. It was beautiful. And we could find them. It was lovely. We could find our clients. But half the time, it's like you have to know which soup kitchen do they go to for lunch, and you just go hoping they show up, kind of thing. So I've done a lot of that to find people.
What motivates you to do this work?
I've been in the community, my whole life. I came out at 18. I lived in San Francisco through the 90s when it was really decimating the community, so I saw it up close. I didn't become a nurse till later in life. And I actually wanted to do hospice work, was my original goal. And due to a series of events, I was not able to do that path, but I found my way to care team, and it fit. It's not the community it was when I was younger, living in the city in the 90s, but 80s and 90s. But it's still my community. It used to be all the pretty gay boys, and you just watching them waste away. I had a friend who got out his address book, and he showed it to me, and every page was full of names crossed out. Crossed out, crossed out. Every now and then there'd be somebody still alive. Your whole social network gone. I mean, it's heartbreaking. So when I had a chance to work in it, and I got an opening to originally do some volunteer work with Care Team, and then eventually hired on when they had an opening, it just fit, because it is still my community, even though it's not the gay disease it was. It's much broader than that now. They're my people. And if you had told me that I would come to deeply love some old smelly homeless guy, I never would have thought it was possible, but I love my clients, most of them. And especially the old timers. They have something, the ones that have had HIV for 20, 30 years. Those people, they've been through the trenches, and anything I can do to help them, I want to do, because they're my people.
Yeah, you went through that together in some ways.
Yeah.
Thank you. Can you speak to how HIV is no longer a death sentence, but more of a chronic health condition, and how that changes the needs for care?
So, I mean, we all know HIV was a death sentence in the early days. There was no treatment. And then when treatment started, AZT, it was a game changer, but they were using it at such high levels, the toxicity of the drugs. So a lot of the long-term survivors have a lot of issues from the use of all those drugs when they were still figuring things out. But now, one pill once a day. I mean, that's what a new diagnosis person is going to be given, a one pill option. And it's not even the big giant horse pills it used to be. It's like a reasonably sized capsule. And that changes everything, because you don't have to have handfuls of pills that you take 2 and 3 times a day, which is what they did. And there are still people who need that. So if you are poor with your adherence, the virus learns to work around the drug, and you develop resistance, just like there's antibiotic resistant stuff, there's antiviral resistant HIV. So it could make a whole class of meds not work for you, and you need to hit the virus with 3 different classes of meds that interrupt the replication in 3 different spots. This is more than you probably want, but you can edit it out. So you have to hit it with from all these pills. So people who develop resistance might have a whole class out. They might get to a place where they can't even do a 1 pill regimen. And so there are still people taking handfuls of pills, but they are the exception. And it's because of resistance it's built up from poor compliance. But to be able to take 1 pill once a day, if you're housed, it's just a matter of learning the routine, you know. If you take that 1 pill once a day, if your viral load's low, if your viral load's suppressed, and you can't transmit it. If you have no viral load, you cannot transmit the virus. So the public health mandate is to get everybody to a undetectable viral load, so there's no transmission. And so it changes everything. You can have sex without giving it to people. You can have babies. You can live your life. I mean, we find that people who have been on meds consistently, well controlled their HIV, this is not including people that were on the old meds, the toxic meds, but pretty much they might start getting some of the issues of old age a little early. They might get some of the same stuff that everybody gets at 60, they might get closer to 50. You know, so there is some effect. Even if you are perfect and take your pill and have your virus suppressed, there's a certain amount of inflammation in your body from the virus that will make issues of aging come a little earlier. But otherwise, totally, absolutely normal. You know, the docs watch you for things that can happen with HIV. You know, there's certain kinds of cancers, there's certain kinds of things that are more common in people with HIV, so they do some extra surveillance. But really, take the pill. It's pretty much normal life. it's pretty miraculous, really.
So how have the needs for care changed since it's not a death sentence? What is it more about now instead of end-of-life care?
Well, before it was hospice work, right? It was gathering around the support to support this person through their death. That's what care was. Now it's about getting them healthy to have a normal life, you know? So the people I serve are people that have a hard time with taking the one pill once a day and getting their labs once a quarter, and a few of the, you know, people that have issues with mental illness or addiction make up the vast majority of my client base. And so, but having to worry about the opportunistic infections and stuff, there's a list this long of opportunistic infections that you get with HIV. And you can still get them when you don't know you have HIV and your CD4 count gets very, very low. It might be getting one of those opportunistic infections that leads to the diagnosis. But if you're on your meds, that just goes away. That just goes away. You know, I've seen one person with KS ever, since I started this work. And that used to be like the most common cancer that would hit people. Pneumocystis pneumonia is one that happens a lot, and that's one that people often, that's how they get diagnosed. But MAC, some of the other things that were just so common before, I'll see a little bit of thrush once in a while down the throat. But again, it's either somebody who is too disorganized and either mentally ill or addicted to take their meds, or somebody who's not been diagnosed yet. It's very different. And it means my client base is all pretty compromised and unorganized. I'm able to manage that.
Can you tell me about the role of HIV care team nurses during the AIDS crisis?
Well, as I've said before, it was hospice work. You know, it was coming in and bringing in care for end of life. And I know there were rules broken, you know. It was kind of a little Wild Westy in trying to figure out how to get people what they needed. But all that mattered was giving these people the respect they deserve, because there was so much hatred and so much bigotry aimed at folks with HIV back then. You know, we finally found a dentist that would give dental care. You know, it's like so basic, nobody would touch them. That was the early days of dientes. And these folks were, even now, starving for touch. People were afraid to touch. And so just even a hug or holding someone's hand was a radical act. And I mean, they were doing all the stuff that any home care nurse does, bringing in, you know, the support if you need a hospital bed, if you need oxygen, if you, whatever you needed, getting it there and making sure they were cared for, making sure the circle around them is cared for. Again, this is all before my time, so it's what I've heard from the legendary nurses. But it was, and that's kind of why I got routed there, because people who knew that history said, oh, this is like hospice work. And I got there, I'm like, no, it's not anymore. But this is good. I can do this. I like this work. I like knowing my clients for decades. And, you know, as opposed to just a couple days and they're gone up in the hospital. So Santa Cruz AIDS Project brought in the community support. They brought in the volunteers. I had one of my closest friends led the masseuse volunteers and coordinated everybody getting massages because they were so starved for touching. And just such a loving, caring thing to do. But they would collect from the community, they would organize volunteers, they would collect food, they would do all the community support for our clients, and then we would do the medical and more institutional support. We would come together for that, around supporting the client. So we worked very closely together. Even when I got there, we were still once a month having a case conference with care team, going over the clients we share, that what their needs were, how we can work together. There are some clients who would not work with care team because we are the government, and would only work with SCAP. So we kind of try to sneakily give support through SCAP to them. Things like that. So we worked closely with SCAP through until they were gone, as they got smaller and smaller. And it was, losing them was a huge, huge blow. By the time I came on board, they were mostly doing food and housing. We had a food bank once a week, which was a social event for the community. It was really lovely. And they had the HOPWA money, so that's the Ryan White Housing Assistance, which, for reasons I don't completely understand, the county can't administer, because we can't give money to people that way. So they administered that, and it helped people when they couldn't pay their rent that month, or when they needed money for deposits to get into a place. So we don't have that money anymore because SCAP doesn't exist, and we haven't gotten another agency to take it on. Housing Matters might be, I think, but losing that was huge. Having somebody who really specializes in housing vouchers and works with Housing Authority, we don't have that anymore. Practical support is what they gave. Medical support's what we gave, practical support's what they gave. So losing that was huge. It was huge.
Can you tell me about the decline of SCAP?
Well, the '08 hit everybody hard, right? We had a huge recession. The county had to reduce head count, and so we lost a few head count at care team. And a lot of funding dried up for SCAP and for most nonprofits. And that's when a lot of smaller nonprofits went under larger umbrella nonprofits. And SCAP went under Encompass. I forget what they were called then. SC4. They've changed names like 5 times. And that never really was a good fit. They never quite knew what to do with SCAP. And so the staff were not getting the support they were promised. Patty, the executive director, retired, and she wasn't, I don't know, they replaced her with this. Anyway, they never really got somebody in there. They tried a couple people that just didn't work, and then pretty soon they just reported into somebody else in some other program. It's only because of the dedication of the individual case managers that they continued to work. There have been numerous times where they're done for, they'll be gone by the end of the year, and the individual case managers would pull it together and make it work. But it got to the point where Encompass just wasn't willing to do the paperwork for the grants anymore, and they just closed it down. So, I don't know. I saw the writing on the wall for quite a while, but it still was kind of a shock when it really happened.
Do you feel that the loss of SCAP is both a sign of its success in responding to an immediate health crisis and also a symbol of how people with HIV continue to be marginalized?
I would definitely say that the success is part of it, because it's not visually horrific for the public. They're not throwing money at it anymore. And SCAP was donation driven all the way. I don't know that SCAP being out of, gone is because of the marginalization of folks with HIV. Not that that's not a legitimate issue completely, but in this case, it felt apathy from Encompass about people with HIV. I guess you could call that marginalization. But in a sense, like you said, the success, people say, well, what's the difference? They have HIV. Doesn't make a difference, you know. They can access the same benefits and stuff that everybody else can. So yeah, I guess both played a role. It's just sad, mostly.
What do you wish people knew about HIV?
Well, there's still a lot of people that don't understand that it's a chronic condition and don't understand that if you suppress the virus, you can't transmit it. And that in and of itself is huge. You know, I still have clients who, when they test positive, their families like, can we share dishes in the kitchen with them and things like that? There's just no education about transmission. I wish people understood how hard it is to transmit it outside of sexual activity. But even so, just the U equals U. You know, they started that campaign 6-8 years ago. Undetectable means untransmittable. If people just knew that, it would be huge.
Is there anything else that you want to add before we wrap today?
Yeah, I mean, I did talk about SCAP and housing and the HOPWA money. That's a big deal. I think that's one of the biggest deals. And also just individual donations aren't what they were. They used to get money from some Broadway nonprofit that's in the money every year, and that was what they funded the food bank with. Care Team used to get money from the estate of somebody. The Diversity Center would manage it for us because we can't have money. Diversity Center didn't want to do it anymore. Person stopped giving money. You know, things, people aren't invested like they were. That's why it's changed. Rather than give more benefit to people with HIV, I'd rather give more benefit to everybody. You know, I think any chronic condition, any marginalized person with a chronic condition deserves case management to deal with it. You know, I spend more time with my people sometimes helping them manage their diabetes or their heart disease or whatever else is going on in their life. Their HIV is beside the point, often. They just take the pill. I wish everybody, every marginalized person with a medical condition could get case management support. It would be the best bang for the buck for keeping people healthy and keeping the community strong.
Do you also wish that every marginalized person with a chronic health condition had stable housing?
Well, yeah, that goes without saying, kind of. You know, I always say if I can get them housed, I can keep them healthy. But, I mean, the housing is so big, and it's not just here, it's everywhere. Yeah. I don't even know where to start with that one. It's huge.
Yeah. Housing is health.
It is. It is.